Okay, before we do the upper cervical specific, I'd like to just quickly run through the quick scan. Hopefully, you're going to be practicing the quick scan almost daily. It takes a while to get used to doing a subtle little movement that you'll see me doing. And then to get a sense of joint play, you really should go and look at the hand and wrist or the foot, where I explain using the interphalangeal joints exactly how to test for joint play and how to feel it. And if you jump ahead to that, you'll get a really good sense of what I'm talking about when I talk about springy end feel. Okay, so I would have done the quick scan, just feeling the sacrum, SI joints, up through the lumbars. You see how subtle it is. It's not hyperextending and flexing and hyper and pushing. It's just a subtle little push. And it'll pick up a block. We'll go on up through, do the cervicals, and then a little push. And let's assume that we found the occiput isn't moving properly on the atlas. And for that, we'll specifically palpate. Retract your neck a little bit. That's it. And now I'm going to push just on the occiput here. My finger's going to palpate just in front of the tip of the transverse of the atlas. And the first little movement, just relax. The first little movement is the occiput gliding on the atlas. If you go too far, you're just really gliding the cervicals. So we want to pick it up very early on in this glide. Just a little. And then go to the other side, because it can be unilateral. And just that little bit of springy end feel. Then we palpate the tip of the transverse of the atlas with our middle finger on each side. Index finger, thumb behind, and rotate A to P, and the tip should disappear behind the mastoid. So we've decided that we need to know specifically whether we have to adjust the occiput or not. And so we feel a little springy end feel. The patient retracts their neck a little bit, and then we feel that first on springiness. It can be unilateral, so we have to do the other side. Now we palpate the tip of the transverse, and if we rotate to the right, the tip of the transverse goes behind the mandible on this side. On the other side, which was doing that action, the tip of the transverse goes behind the mastoid. If you can still palpate the tip of the transverse when you've done these movements, it means that the atlas and the occiput have moved together, and they're blocked, and they need to be separated. And to do that, we need occipital contacts. If you take an atlas contact, you're going to move atlas axis. And we repalpate, and that's how we know that. If we take occipital contacts, we're going to move the occiput on the atlas. There's three ways. We're going to do it prone, we're going to do it sitting, and we're going to do it supine. And these are called occipital lifts. And luckily, the one maneuver, the occipital lift, corrects all the dysfunctions between atlas and occiput. So when we're finished, it'll glide forward, it'll rotate, and it'll even side bend, which there isn't a lot, but that little springy side bending is also palpable. But I find that if I find one block, I know I'm going to be adjusting the atlas occiput, and I'm going to get everything anyways. Okay, Joss, if you'll lie face down. I'm going to lower the headpiece 20 degrees or so. I'm going to take my middle finger. I'm going to get in front of his face and underneath the rim of the occiput. Now the rim, this is the occipital protuberance, the mastoid. The rim is in between. And there's a nice ledge there that my middle finger is going to hook on. And that finger is going to be pulling as I lean away so that I can feel distraction between the atlas and the occiput. My other hand, the forearm's going to be the impulse, and I'm going to cause lateral bending with the distraction, and we're going to get an occipital release. So if I want to move his left atlas occiput, I'm going to turn the left side down. I'm going to reach in front and get under the rim. So my middle finger is right there underneath. My hand is going to be floppy loose, so I don't pull on the chin. But my forearm is going to be on the temple. I'm going to lean away. He's going to relax and breathe out, and I'm going to impulse. And he just felt his occiput release off the atlas on the left side. Let me do that on the other side so you can see the hands and you can see the impulse again. So I'm going to reach under so that I get this rim in front of the face. There's the protuberance. My fingers aren't over here. They're underneath the rim. My hand is loose so that it doesn't pull on the chin. My forearm causes lateral flexion. I lean away, impulse. And that causes a lift of the occiput on the atlas. Okay, Holly, if you'll come and sit over here. That's it. I'm going to have her sitting as upright as she can. There we go. Good. In my office, I use an ordinary chair. In a house call, things like that. You don't need a specific chair with the back that moves. Just an upright chair is fine. She's going to have her feet flat on the floor, no crossed legs, everything relaxed. I'm going to turn her head, and this time you'll see that rim contact. Those earrings going to hurt you? Nope. So we're under the rim. Remember, we tilted the head away because the headpiece was down. I'm going to put my sternum against that, and just above. There's a nice little hollow here. Unfortunately, the mic is here, so we'll move that over. There we go. My knees are bent. I'm very low. My shoulders are lined up with her shoulders. You mustn't be at an angle. You have to be parallel with the patient's shoulders. Lean over for that lateral flexion. Now I'm going to bend with my knees straightening and do a lift. And this will cause the very same move that that prone caused. We'll rotate this way. You can see it from this side. Underneath the rim, here's the mastoid. I'm just underneath the rim. Look at my shoulders parallel. Get my sternum just above, contacting her temple, cranium. Reinforce, lean forward, lift, feel it tractioning, impulse. And that time we got a nice little lift of the occiput off the atlas. Okay, Casey, if you'll come over here. This time, we're going to give Casey a little more support. Always check your table is set up properly for the patient. This time we're going to pull on the rim of the occiput. I'm going to have a piezoform underneath the rim on the other side. These are occipital contacts to move occiput on atlas. I'm going to side tilt a little bit. I'm going to lean away for traction. And now I have to impulse. You don't want fast hands. You want an impulse. This is a very little gap that has to occur. So I get under the rim. That pushing my hand a bit, so we'll just lower it. We'll get under the mastoid on the other side. Now I'm going to lean away, tilt it a little bit. She has to relax, and I impulse. And on this, the upper one moves. You're pulling, but this hand is going to cause the release because that's the side that it's side bending to just like it was prone and sitting. So I'll do that from the other side so you can appreciate it. We're going to get under the rim. My palm cups the ear, turn the head, bend your knees, get your sternum near your hands so you're strong, lean away, side tilt, impulse. And we get a little release of the occiput on the atlas. Okay, do you mind coming over and having a seat here? So now that we've moved the occiput on the atlas, we're going to take a contact on the posterior arch of the atlas. And if it's not moving, it'll be because it's not moving with the axis. And that way we'll take atlas contacts to move atlas axis. Come off the rim, pick up the posterior arch. My fingers are this way and not this way. The reason for that is I'm going to use my tendons, which are loaded with receptors to palpate with. Pushing straight on, people can put their fingers through drywall with that. It doesn't hurt at all. But as soon as you start this, your head's thinking, oops, we're going to hurt our fingers here. So they get very sensitive. So we're going to use that sensitivity. Slide off the rim, pick up the posterior arch, rotate it P to A. Bring it back. Extension. Now I'm not extending her lower cervicals. The extension has to occur right at my finger. Right there. Rotation. At a sort of a contralateral here. That's it. Block it and see if it laterally flexes. Now the atlas axis doesn't have active lateral flexion, but it has joint play of lateral flexion. So you're going to need to adjust it from P to A, extension, and lateral flexion. Then it also needs flexion and A to P rotation. So that means in the cervical spine, we can get positive, negative theta rotation around all three axes. So we're going to be able to adjust from P to A extension, from P to A rotation, at an angle, P to A lateral flexion, flexion, A to P rotation. We're also, when we did that occipital lift, we were creating some long axis distraction because in the upper cervical spine, as we turn our head, the spine screws itself down and then unscrews itself. It has this distraction up and down. So from the other side, you can see what my hand is doing. I'm bringing her back in extension. I'm using it to rotate. I'm laterally flexing. I go in front. I'm flexing. I'm A to P rotating. I'm going to take a contact with my pisiform or my index finger. I like using the pisiform because when I impulse, my fingers can't bend. Plus, if you use your fingers, you have to create tension in your fingers, which the patient picks up on, and then they tense up. So even though it's classically done with fingers, years and years ago, and I was certainly taught this in the late 50s, was we used our pisiform. And that way we could keep our hands soft, the contacts could be soft, the patient could relax, and we could get very easy manipulation. You first of all have to learn to cup the ear, get your middle finger under the rim of the occiput so that you have complete control of the head. Don't be up here like this. All right? When you're like that, the head's falling all over the place, so the patient has to tighten their neck muscles. You want them to feel that you've got them, you're under the rim with your middle finger, cup the ear with the palm, thumb is relaxed, I have complete control of his head. Now I'm going to put my pisiform, I'm going to slide off the rim of the occiput and pick up the posterior arch of the atlas. If it didn't rotate, I impulse rotation, and we get a very easy release. I'll show that on the other side. Cup, control, slide off the rim, pick up the posterior arch, pure rotation, impulse. And we get a very easy rotation of atlas on axis. For lateral flexion, I'm going to have a similar contact. Cup the ear, under the rim, complete control of the head, come off the rim of the occiput with my pisiform, make contact with the posterior arch of the atlas. Only this time it's kind of slight rotation, but more lateral flexion. Get my sternum down near my hands and impulse. Feel the resistance, impulse. Come off the rim, get down near your hand, it's near your sternum, take out that lateral flexion to resistance, impulse. There's nothing there, so we didn't get an audible release. If we wanted to do extension, we can come in behind that posterior arch and bring the head into extension. However, if you turn over face down, we're going to use recoil. It's much better for extension. We'll set the headpiece so it has a drop. I'm going to take a bilateral contact on the atlas, just on the arch, so that my thumb and index has it. I'll super reinforce that. I'm using my middle finger over my index, my thumb over thumb, and I can feel now that it doesn't extend. So we need to set, and I'm going to do a recoil. The headpiece is going to drop, and this has got to be very fast. And what happened was, as it did that, we got a separation for extension. So we've done rotation P to A, lateral flexion, extension. Now we need to go flexion, A to P rotation. These are the two restrictions in the cervical spine from the top to the bottom that has the most effect on the sympathetic nervous system. And as you know, if you read Bosbaum and Levine, sympathetics that are facilitated cause the release of norepinephrine at an injured area, and it turns acute inflammation into chronic inflammation. Hence, there's literature to show cervical manipulation clears up tennis elbow, helps shoulder inflammations, the extremity inflammations. You have to make sure that you don't have sympathetic facilitation. Just treating them locally like a physiotherapist is not the way chiropractors treat sports injuries. We treat the spinal component of the injury as well as the injury. Extremely important. Okay, if you could turn over onto your back for me. That's it, Holly. I'm going to use my thumb to get just in front of the tip of the transverse. Remember, this is between atlas and axis. So I want my hand to come around off the rim and try and pick up the posterior arch. I can't feel it, but I'm just behind it. My thumb is just in front of this transverse. Feel resistance, and I'll impulse. And this will cause a release of A to P on the left side. Let me show you that from the other side. I have my thumb in front of the tip of the transverse of the atlas. I'm going to reach around with this hand so that I'm on the right side of her neck, pulling until I catch the left. Isolate that A to P movement, impulse. And you will get a movement from A to P between atlas and axis. When that's a condition that's present, the patient's face will flush, they'll break out into perspiration, there'll be facilitated sympathetics. Your adjustment actually aggravates them until they've had a little series that you can adjust them and they don't sweat because it's not facilitated anymore. But obviously, if you adjust where it's facilitated, you're going to get a little increase in symptoms. For flexion, if we come in just in front of the tip and get our index riding past the tip, and just now we have to go, you take out a little rotation and then you bring the flexion. Sometimes I come in with my pisiform where I can get it and come up. This is very awkward. You have to feel the resistance. Impulse. If you have a hard push or a fast push, this is going to hurt. Don't do it. Make sure that you've developed an impulse so that you can do this particular maneuver. It's much more common in the lower cervicals, where I'll be demonstrating it again, and I suggest you learn to perfect it in the lower cervicals before you attempt in the upper cervical. C2, C3 is easier than Atlas axis. Okay, what we're going to do now is a little review of this upper cervical, because we need to change the camera angle so that you can see a little better, and this will be a little more close up. And pay attention to the indifferent hand on the one side, and then the thrust hand will be on that side, and you can, obviously you have to put them together. So first of all, if we're going to move the left side occiput on Atlas, we need an occiput contact on the rim, and the rim is behind the mastoid and not around as far as the protuberance. So I'm going to reach in front of the face. Notice that my arm is going perpendicular or parallel with her shoulders. I'm not this way. I'm there. I'm under the rim. I've cupped her ear. This hand is going to go loose, and my forearm is coming up the length of this spine, so I don't want it at an angle. I want it straight, hand loose. The forearm is the thrust. You lean back, and down below it starts to separate because of the traction, and then you impulse. And that gives you an occiput lift, left occiput from the Atlas. If we turn that the other way, I'll get under the rim. My fingers are not at the protuberance, they're on the rim. That gives me something to hook on. This hand, nice and slack, forearm, it just released before I even got the traction. Notice how I'm leaning away, my forearm, impulse, and we got a little more separation. What we're doing here is we're going to take an Atlas contact so we can do Atlas axis adjusting. And the contact will be just under the rim. We'll pick up the posterior arch. And if I slide my pisiform off that rim, I can hit the posterior arch. My other hand is under the rim, cupping the ear, and has complete control of the head. I got to bend down so that my sternum is going to be near my hands, slide off the rim with my pisiform, take out the rotation, impulse, impulse. On the other side, under the rim, cup the ear, slide off, pick up the posterior arch, rotate, impulse. And we'll get a little release between the Atlas and the axis. For lateral flexion, same contact. Let me show it this time with the index finger, picking up the posterior arch of Atlas. Little rotation, but now it's going to be lateral flexion. Impulse. Impulse into the resistance of lateral flexion. Cup the ear just to show you. Little rotation. Index. Try and keep your hands soft. Pick up the resistance. Impulse. And get that lateral flexion even though there's a little rotation there. Extension. Turn over face down. I like to use a drop mechanism for extension. Just come down a little bit. You have to get the tension different for each patient. There's the posterior arch. Thumb on the posterior arch. Reinforce middle and thumb. Get your upper body relaxed. We're going to flick the triceps and the pecs, and we'll get a recoil to cause extension of the atlas axis. That's really pure. There's no rotation there. There's excellent extension. All you have to do is practice that you can flick your triceps and flick your pecs to get that very fast recoil. Next, we want A to P rotation. What I'm going to do is hook my thumb in front of the tip of the transverse. Cup the ear. I'm going to come around from the other side and pull until I get to about the posterior arch of the atlas on the right. I need the tension, impulse, and the push with my thumb and the pull with my impulsing will cause a rotation from anterior to posterior. I'm going to show you flexion of the atlas with the axis. This is a move that you probably be a year or so before you get a fast enough impulse and that you can really attempt to do this. However, we're going to learn it in the lower cervicals, which you'll be able to do much sooner, and you'll get a real good sense of how the cervical spine should flex. So here we go. We need to bring our pisiform or our thumb. We have to come up into flexion. You need a little rotation to trap it. He has to let his neck drop, and I have to impulse down. It looks like it's a rotary, but it's actually into the flexion first. It releases in flexion. That's a very difficult maneuver, and don't start there, please. Okay, it's been shown biomechanically that when we turn our head, the atlas screws itself down onto the axis. So there's actually a translation on the y-axis. And what we've done traditionally in chiropractic is we've used our middle fingers and we've literally hooked under the occiput and leaned away and did a little impulse to get that specific distraction. If you use a towel around the neck and tighten it over the forehead, you're getting distraction of the whole cervical spine. I prefer that whatever level you want this to be at, get your middle fingers at that level, lean away, distract, and you can feel them separating right at your finger, your middle finger. And that covers the last movement for the cervical, upper cervical region. Next, we're going to do the palpation specifically of the lower cervicals and the specific manipulations. Okay, now we're going to motion palpate from C2 on down. And I should warn you that a lot of the cervical dysfunction that you're going to palpate will be secondary to atlas occiput atlas axis, to the upper thoracics failing to glide anterior, to the first rib failing to participate, the clavicle, sternoclavicular joint, and not functioning properly are all part of the closed kinematic system for the cervical spine. So be very careful that you don't end up adjusting the cervical spine 4, 5, 6, 7 times the same way every time, visit to visit, and leaving somebody with a first rib that's dysfunctional, or a clavicle that isn't rotating, or the upper thoracic's not gliding anterior, which we call extension. They can all influence the cervicals. But let's assume now that we know all those primaries are not present and we want to adjust the cervical spine. We're going to turn our hands the same way forward, and we're going to slide off the posterior arch of atlas and pick up the articular pillar between C2 and C3. Extend, not hyperextend, just the first movement of extension. P to A rotation, and just kind of posterolateral for lateral flexion. We'll go down one, extend, rotate, posterolateral lateral flexion. Do you notice that I'm jiggling the head to feel the springy end feel. We have here a block in this posterolateral lateral flexion. So I would say to a patient, does that hurt? Can you feel that?
Yes.
Yeah, she can feel that. So after I do a manipulation, I should be able to come back and duplicate this palpation, feel it springy, and she shouldn't feel that pain. And when I let go, there's no pain. So this is typical of the pain response of a manipulable lesion. So we'll go all the way down: extension, P to A rotation, lateral flexion. Extension, P to A rotation, lateral flexion. And down here she's extremely mobile, because up here, this second, third, they're not moving as well as they should, and they're forcing the movement into the lower cervicals. Then we turn our palm up so that we can bring our finger just in under the atlas, pick up the axis, flex it. And this will be extremely painful when it doesn't move. So you've got to be very gentle. And she doesn't flex. Can you feel that?
Yeah.
Yeah. If you did that a little more strenuously, she would start to get the response, and she is. She's just starting to get sweating a little bit, because I'm tripping up that sympathetics that are facilitated. She could highly likely have headaches, ringing in the ears, not her, but a patient, blurred vision, dryness of the throat, pain up over the head, headaches, pain down into the shoulder, pain into the front of the shoulder, numbness and tingling down the arm, all kinds of symptoms, poor digestion, heart rate and palpitations of the heart, all the signs of the fight or flight mechanism, the stress response. The stress response is triggered by sympathetics. What the scientists haven't discovered yet is that spinal dysfunction can trip up the facilitation of the sympathetics that tips the patient into that stress response as well. That's the future. That research is just starting to happen. We have doctors of chiropractic who are PhDs in neuro facilitation, and they have the ability to mark and determine the norepinephrine release on facilitated sympathetics before and after a manipulation. We're not that far away from showing the relationship between that and chronic inflammation. So this palpation is extremely important, and it's sadly to say not done consistently as a standard in our profession. So hopefully we're going to change that. So we'll literally go down the front just where the scalene attaches to the transverse, and we'll pick up the flexion. She flexes pretty well down here, but up in here it's terrible. Now we're going to rotate that A to P. So we'll pull it around A to P all the way down. And she moves really well here, but as soon as I trap it in here, she's not moving A to P very well. So we did extension, P to A rotation, lateral flexion, flexion, A to P rotation of the cervical spine. Each of those has a manipulation. If you don't mind, I'd like to do those A to P moves on you. If you'd lie on your back. So, on her right side, she failed to flex and she failed to go A to P rotation. If I place my thumb just in front of the SCM, I can pick up that spot that wasn't flexing and going A to P. With my opposite hand, I'm going to reach around and get in front of that contact that I was feeling with my thumb. I'm going to reinforce that by placing my thumb in front of that. Now I'm sliding, and my left index finger is back by the spinous. My thumb is in front where that fix, and I can feel the resistance. Now I have to straighten the scalenes and impulse. And that will give me an A to P rotation between C2 and C3 as it was with her. That move can go all the way down. Let's do it on the other side to see. You palpate with your thumb to find the resistance. You bring your hand underneath and get that contact. Cup the ear, pull, my fingers sliding, scalenes taut, impulse. Impulse. The impulse is with both. It's not that. It's not that. It's just that. Impulse. For flexion, I'm going to take my index finger and bring it right down on top of that contact and bring her neck into flexion. Notice how I get my sternum near my hands. She has to let her neck drop to the table and I impulse. And that's going to cause a flexion release. Some people put a little more rotation into it. Get in front, just let it go, and impulse with a little rotation and flexion. It's not necessary, you can get pure flexion. For P to A rotation, I think, Josh, if you come over, lie on your back. Remember, we palpated P to A rotation, P to A extension, lateral flexion. So again, you need to come well behind the articular pillar. A lot of people take a contact on the side and don't get behind the articular pillar. Getting behind the pillar facilitates this manipulation, makes it much easier and much more comfortable for the patient. You don't have to turn the head as far, and it's just better all around. So we're going to get in behind. You can use your index, drop this shoulder. You can use your index or your pisiform. Turn, rotation, impulse. So that's a P to A rotation. For extension, again in behind, bring the neck back into extension and impulse up into extension. Lateral flexion, same thing, in behind the articular pillar, bring the neck laterally, lower yourself, impulse. Each of those you feel the resistance. From the other side, I've cupped the head, my middle finger is under the rim. I have complete control of the head. The contact hand is behind the articular pillar. My hands are at the same level. So I'm not like this shearing. I have my hands, my middle finger's cupping the rim, my index, my hands are at the same level. I rotate, impulse with the rotation. Lateral flexion, extension. All controlled by the two hands together at the same level. My sternum near my hands. Never be out here trying to adjust. Notice my legs are bent. My sternum is close. I'm strong there. Straighten your legs. Get away. You've just weakened yourself. Okay. Long axis distraction for the lower cervicals. Middle fingers between the spinuses. Cup. Lean away. Little impulse. And that pretty much covers supine adjusting of the cervical spine. Okay, there are lots of doctors that prefer to adjust the cervical spine with the patient sitting. There's times when that's the only way you can adjust the cervical spine. Patients can't lie, just had a big surgery on their back, removing a melanoma or something like that, and you've got to have them just sitting up. It's the same thing though. We're going to either be doing extension, P to A rotation, lateral flexion, flexion, and A to P rotation. It's kind of silly to think that you can just take a patient, crack their neck once in one direction, and it's going to clear up all the rotations around these three axes. So it'll become important for you at a motion unit that's between two vertebrae to make sure the patient gets it cleared in all the directions, both sides. So you might go P to A on the right, and you might go P to A on the left. And that's because you're adjusting joints. You're not adjusting the vertebra. You're not trying to put the vertebra into a place that makes it rotate. You're actually trying to adjust the joints. That's what cavitates. That's what science has shown changes. Position, joints can move and position can change, but that's not what you're doing with an adjustment. You're changing the dynamic function of the joints. So let's say we have here between 2 and 3, failure to extend, P to A rotate, and laterally flex. I'm going to tilt my hand so that my index finger comes from the spinous in behind the articular pillar. I'm going to cup the head so that my fingers are at the same level. I'm going to move to the side, rotate for P to A rotation, and impulse. If it's lateral flexion, I'm going to rotate a little bit, but laterally flex, impulse. If it's extension, I'm going to come back. There's a little rotation needed to block it in extension. This time I'm going to thrust into the extension, and that'll be that little short, sharp impulse. To show it on the other side, hand down. This hand cups the ear. Hands are at the same level. It's turned to the side. Get the rotation blocked. Impulse. Laterally flex. Impulse. Extend. Impulse. The little rotation and impulse. Now for flexion and A to P rotation, I'm going to stand on the side. That's it. And with my pisiform, I'm going to come in front of the sternocleidomastoid, just where the scalenes attach, and I'm going to get my pisiform planted into that resistance. I have to bend down to get strong. I'm going to tilt the scalenes, rotate, feel the resistance, impulse. For flexion, it's the same. Just tighten the scalenes, impulse. And this is a little harder maneuver to do, but there's a Dr. Adrian Grice in Canada that discovered this move, and he's taught a lot of people how to do it very well. I'll do it if I have to go to the sitting posture. I much prefer doing it supine. Okay, we're just going to take a little different angle here to see this sitting A to P rotation of a lower cervical, or even at C2-3. Get our thumb to palpate and bring our pisiform in front of the trapezius here, in front of the ACM, and just get on where the scalenes attach. And now you're going to make the scalenes go taut and rotate so that when you push with your pisiform, there's going to be a P to A impulse, a P to A. My hand on the other side is at the same level, and we're doing a P to A impulse. There are a lot of patients that have very strong neck muscles, and there are a lot of chiropractors that weigh 100 pounds or 110 pounds, and they really don't have the strength to control a very large neck. And when that occurs for me, then I use a prone posture for the patient and drop recoil. And you hopefully see here that I can do extension, lateral flexion, rotation, but obviously I can't do A to P rotation and flexion. So let me demonstrate that. I'm going to use, we'll come into C3-4 here, and I'm going to place one thumb behind the articular pillar and my index finger on the other side behind the articular pillar. I'll have loaded the headpiece so that it drops, and I'm going to reinforce the thumb, reinforce the index, and get straight over the patient with relaxed arms, elbows slightly relaxed. Relax your triceps, relax your pecs, and give a very quick impulse for extension. If I was to do that for rotation, P to A on the left side, I'm going to take a double thumb contact on the left side and let my fingers go slack on the right side. Take out the tension, relax my triceps, my pecs, and give an impulse, and that'll cause releasing the joint on the left for rotation P to A. Now let's say he didn't laterally flex to the left. I'll set the, and this time I'm going to have to get down so that I can get lateral. This headpiece will drop again, but I have to feel the resistance of lateral. I have to relax my triceps and give a lateral thrust. And with elderly people, although that looks like it's a lot of force, I can take people that have some degenerative changes in their cervical spine that I really don't want to rotate their neck. I can leave them face down and get really good extension, rotation, lateral flexion. I'll go to the other side and you can see the fingers. Here's the articular pillar. My thumb is on the articular pillar. My other thumb is on the articular pillar. My index reinforced by the middle. Straight over above. Set the headpiece. Don't lean too much, but you do have to take up the tension. Relax the triceps and let it fire. We're just going to review that so that you can see my shoulder position and how my elbows are not flexed too much. So I'll take a contact in behind the articular pillar. I will have decided that I'm going to go into extension, reinforce, get myself so that I'm loose and that my elbows are loose but not bent very much. I'll set the drop headpiece. Again, get myself so at my elbows, but you have to be very relaxed so that when you fire, you get a very short, sharp impulse. My shoulders were square, my elbows were just slightly flexed, just hanging normally really, so that when I do that, I get a few millimeters of drop, enough to fire that drop headpiece, which is instrumental in magnifying the movement. Okay? So what's happening here is my elbows are not bent like that, so that when I flick my tricep, my hands drop an inch or two. I have my elbows just loose, but when I contract my tricep, I get a little hyperextension of my elbow, which drops me a few millimeters. So I'm relaxed. You can practice it holding on to your thumb. Let your pecs go nice and relaxed. And flick, flick, and get that very nicely controlled drop with a recoil. It's a shame that this recoil is being lost by many of the practitioners in our profession. It was standard in the 40s and 50s, and it has an extremely good use when you don't want to rotate the neck and you need to get mobility in the cervical spine. It's well worth learning. Thank you.